Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. In this session, I will be discussing a very important topic in the cardiology, that is the heart sounds. So, the heart sounds, we have first heart sound, second heart sound, third heart sound, and then the fourth heart sound. So before going on to the discussion of the individual heart sounds, you need to know where exactly is the location of these auscultatory points, right? So you need to know where all you need to auscultate for listening to this particular heart sounds. So if you see a question accordingly, which is the location of the Erb's point during auscultation? First option is second intercostal space, right parasternal line. Second intercostal space, left parasternal line. Third intercostal space, left parasternal line. Fifth intercostal space, left parasternal line. So what are the areas of the auscultation? So we will discuss and then come back to this question. So if you see the areas of auscultation, so first important thing is the aortic area. So this aortic area, it is present in the second right intercostal space adjacent to the sternum. And if you see the pulmonary area, it is present in the second left intercostal space adjacent to the sternum. That will be the pulmonary area. Then the Erb's point, it is present in third left intercostal space adjacent to the sternum. Then the tricuspid area. So tricuspid area, it is present in fourth left intercostal space adjacent to the sternum. Then the mitral area. Mitral area, it corresponds to the apex of the heart. Right, mitral area, it corresponds to the apex of the heart. So these are the areas of the auscultation: aortic area, pulmonary area, then Erb's point, tricuspid area, and then the mitral area. So after having discussed about the areas of auscultation, now let me discuss in detail about the first heart sound. The first heart sound signals the onset of left ventricular contraction, and it consists of, so before that you see the question what I have shown you in the beginning, which is the location of the Erb's point now? That will be the third intercostal space that is in the left parasternal line. That will be the Erb's point. Now after having discussed about the areas of auscultation, let me discuss the first heart sound. So first heart sound signals the onset of left ventricular contraction and consists of two major audible components and two inaudible components, two major audible components and one inaudible component, one major audible component and two inaudible components, one major audible component and one inaudible component. So let me discuss about the first heart sound in detail. So the answer in this question is the two major audible components and two inaudible components. So if you see the first heart sound, it signals the onset of the left ventricular contraction. Right, it signals the onset of left ventricular contraction. That means during which phase of the cardiac cycle you will have this first heart sound? The first heart sound, it is heard during isovolumetric contraction phase. And this first heart sound, it consists of the two major audible components. And what are these two major audible components? These two major audible components include the mitral component and as well as the tricuspid component, that is M1 and as well as the T1. So it is the vibrations which are generated within the mitral valve and tricuspid valve will constitute the major audible components of the first heart sound, and there are two inaudible components as well. Right, there are two inaudible components as well. Now what are those audible? We have already discussed. So the first, what are the audible components? M1 and T1. Then what will be that inaudible components? The first inaudible low frequency vibration, it coincides with the beginning of the left ventricular contraction and it is muscular in origin. Okay, so the first inaudible low frequency vibration, it coincides with the it coincides with beginning of it coincides with the beginning of the left ventricular contraction and it is muscular in origin. That is about the first inaudible low frequency vibration, right? That is the left ventricular contraction which is muscular in origin, and it is followed by the two audible components, right? And these two audible components, M1 and T1, both of them, they are the high frequency components. Right, they are the high frequency components which are produced due to closure of mitral and tricuspid valve. Right, which are produced due to closure of mitral and the tricuspid valve. And again we have the last low frequency vibration. And what is this last low frequency vibration? This coincides with the opening of semilunar valves with ejection of the blood into aorta and pulmonary trunk. So this coincides with this coincides with the opening of, and this coincides with opening of semilunar valves. Right, so this is about the four components of the first heart sound. So one is the low frequency vibration, which is the beginning of left ventricular contraction and muscular in origin, and two major audible components, that is M1 and T1, and inaudible low frequency vibration, the last one, it coincides with the opening of the semilunar valves. Now let me discuss in detail about the first heart sound. You see a question here. An intern was asked to auscultate the first heart sound and he said he cannot differentiate M1 and T1 separately. He cannot differentiate the M1 and T1 separately because the distance between M1 and T1 is more than 30 milliseconds, 20 to 30 milliseconds, less than 20 milliseconds, 40 to 50 milliseconds. So if the duration between the two sounds, if the duration between the two sounds, if it is more than 30 milliseconds, that is only the point when we will be able to differentiate the two sounds separately. But here the duration between M1 and T1, it is 20 to 30 milliseconds. The duration between M1 and T1 is 20 to 30 milliseconds. So that means it is less than 30 milliseconds. Now because the duration is less than 30 milliseconds, please remember M1 and T1, both of them, they cannot be differentiated separately. Both of them, they cannot be differentiated separately. And if you take the characteristic features of the first heart sound, the frequency of the first heart sound is medium to high frequency sound. Right, it is medium to high frequency sound. And the duration of the first start sound, it is 0.14 seconds. And the distance between M1 and T1 is 20 to 30 milliseconds. Right, the distance between M1 and T1 is 20 to 30 milliseconds. And the C point of mitral valve echocardiogram, it coincides with M1. Right, it coincides with M1. And the downstroke of C wave of LA pressure, it also coincides, right, it also coincides with M1. And downstroke of C wave of RA pressure, this coincides with this coincides with T1. So these are the characteristic features of the first start sound. The frequency is like medium to high frequency sound. The duration is 0.14 second. The distance between M1 and T1 interval is 20 to 30 milliseconds, and the C point of mitral valve echocardiogram and downstroke of C wave of LA pressure coincides with M1, and downstroke of C wave of RA pressure coincides with the T1. Now, so whatever I have discussed until now, these are the points related to a normal first start sound. Now let me discuss the conditions where you have the soft first start sound and the conditions where you have loud first start sound. So you see this question. First start sound, it is soft in all except short PR interval, ventricular septal defect, mitral regurgitation, the calcified valve. So if you take the causes of the soft first start sound, right, what is the question about? First start sound is soft in all except. So let me discuss all the conditions where you have soft first start sound. So wherever there is poor conduction of the sound to the surface of the chest, like the distance between the valves and the chest wall, if it is increased, then the conduction of the sound to the surface of the chest does not occur. There will be poor conductance of sound to the chest wall. And these conditions include obesity, number 2, emphysema, number 3, pleural effusion, right, number 4, pericardial effusion. So these are the conditions where there is poor conduction of the sound to the surface of the chest wall, right. You take in obesity, there is lots and lots of the fat, and that will prevent the conduction of sound to the surface of the chest wall. You take in emphysema, both the lungs are abnormally dilated, and it is irreversibly abnormally dilated lungs, and they overlap the heart, and thereby the sounds are not being transmitted adequately to the surface of the chest wall. In pleural effusion, you have large quantity of the fluid in the pleural space, and that will not allow the pleural fluid to be that will not allow the heart sound to be transmitted to the surface of the chest wall. And in pericardial effusion, what happens is there is large quantity of the fluid in the pericardial space, and that will not allow the heart sounds to be transmitted adequately to the surface of the chest. So these are all the conditions where you have the poor conduction of the sound through the chest wall. Next, now wherever there is decreased rate of the LV contraction, right, decrease in rate of the LV contraction. So whenever there is decrease in the rate of LV contraction, you will have the soft S1. I will explain you. First of all, I should have explained you the mechanism of the first start sound. Then later on, I will explain you the etiologies causing soft S1. So we will take up the left-sided structures. So this is left atrium, this is left ventricle, and this will be the aorta. Right, this will be the aorta. So whenever the left ventricle contracts, right, whenever the left ventricle contracts, the pressure within the left ventricle increases. And the pressure rise within the left ventricle, okay, but before that you need to know that this is your mitral leaflets, and this will be your anterior mitral leaflet, which is connected to, right, which is connected to the anterior mitral leaflet via the papillary muscle. So this will be your chordae tendineae, right. The chordae tendineae will attach the anterior mitral leaflet to the papillary muscle. Similarly, the posterior mitral leaflet is also attached to the chordae tendineae, and that is attached to the papillary muscles. So whenever there is pressure rise within the ventricle, and that increase in pressure will go and, right, that increased pressure will go and hit the ventricular surface of the mitral valve, and thereby what will happen to the mitral valves? Mitral valves right, they are pushed, right, mitral valve, they are pushed into the atria. So because of the pressure rise within the ventricles, the mitral valve is pushed into the atria, but this chordae tendineae, due to elasticity, it will be pulling the valve. The pressure rise within the ventricle will push the valve into the atria, but the chordae tendineae will pull the valve downwards. So the mitral valve, it is set into vibration, right, the mitral valve, it is set into vibration. So once this mitral valve is set into vibration, then you will listen the M1 component of the first heart sound. The same thing applies even on the right side as well, where even the tricuspid valve is also set into vibration, wherein you will listen the T1 component of the first heart sound when the tricuspid valve is set into vibration. So the pressure rise within the ventricle, right, the pressure rise within the ventricle is very important for the development of M1 and T1 component. But for suppose, right, but for suppose, if there is decreased rate of LV contraction, then the pressure rise within the ventricle will be less, and thereby the intensity of the vibration of your mitral and tricuspid valve will be less, and thereby the M1 and T1 will be soft. So where is that you will have decreased rate of the LV pressure development? That is in patients with hypothyroidism, that is myxedema. Right. Number 2, acute myocardial infarction. See, in acute myocardial infarction, the LV contractility will be reduced because of the death of the myocardium, and thereby there will be decreased rate of the LV pressure development. And then in patients with cardiomyopathy, and then in mitral regurgitation. Because these patients with mitral regurgitation, ultimately at one point of time they will develop left ventricular failure. Once they develop left ventricular failure, there will be decrease in rate of LV pressure development. So in all these conditions like myxedema, cardiomyopathy, acute MI and mitral regurgitation, there will be decrease in rate of LV pressure development, and thereby there will be a soft S1. Then coming to the PR interval. See, if the PR interval is prolonged, right, if the PR interval, if it is prolonged, so prolonged PR interval, where do you have? You will have that in first degree AV block. So in first degree AV block, you will have prolonged PR interval where the individual will have the softer closure of the valves, and thereby you will have a soft S1. So Prolonged PR interval, you will have soft S1. Then coming to the mobility of the valves. Severely calcified valves, like you take in patients with calcified mitral stenosis, right? In patients with calcified mitral stenosis, the valve closure the valve closure is being delayed, or the valve mobility valve mobility will be reduced. And because of reduced valve mobility, there will be soft S1 in patients with the calcified mitral stenosis. So these are the causes of the soft S1, right? So one condition where there is poor conduction of the sound through the chest wall. Second condition where there is decrease in the rate of LV pressure development, like in patients with hypothyroidism, cardiomyopathy and acute MI, and in patients with prolonged PR interval. And fourth, where there is decreased mobility of the valve, that is reduced mobility of the valve, that is also associated with soft S1. So if you see a question here, patient presented with palpitations, weight loss, increased appetite and dyspnea. Systolic blood pressure is 154 millimeters of mercury. On auscultation, there was a loud first heart sound and the second heart sound. What is the diagnosis? Cushing syndrome, acromegaly, Conn syndrome, amiodarone toxicity. So now let me discuss the conditions where you have the loud S1. Among the options given to you, the answer is the amiodarone toxicity. These patients with amiodarone toxicity, they can develop thyrotoxicosis. Right? They can develop thyrotoxicosis. So in patients with thyrotoxicosis, there will be loud first and as well as the second heart sound. So let me tell you the conditions where you have the presence of the loud S1. What are the causes of the loud S1? Number one, the tachycardia. So any conditions, like for example, you take the hyperdynamic states. So which are these hyperdynamic states? That includes anemia, thyrotoxicosis, beriberi, AV fistula, then Paget's disease of bone, then fever. These are all the hyperdynamic states where you have the presence of tachycardia. Then wherever there is increased or prolonged atrioventricular flow. So where is that you have the prolonged atrioventricular flow? Prolonged atrioventricular flow, you will come across that in patients with mitral stenosis and tricuspid stenosis. So already the valve is stenosed. See, one point you should remember, calcified mitral stenosis, mobility of the valve is reduced, you will have the soft S1. But if you take the conditions where you have the loud S1, that will be organic mitral stenosis which is not calcified, right? In a non-calcified mitral stenosis, you will have the loud S1 because the time required to move for the movement of the blood from left atrium to left ventricle is increased, and that particular movement is increased across the stenosed or tight valve. So once the entire blood is moved from left atrium to left ventricle, that stenosed valve which is prolonged, the stenosed valve which is extended or which is open for longer duration will come back to its normal position with a greater intensity, or it will close with a greater intensity. So thereby you will have a loud S1. Then conditions with short PR interval. right? So when the PR interval is less than 0.12 seconds, that is the point when the individual, that is the condition where you have the presence of loud S1. So where is that you will have the short PR interval? You will have that in patients with WPW syndrome. That is Wolff-Parkinson's-White syndrome, which is a pre-excitation syndrome. So there will be an accessory bundle connecting atria and ventricle. So the impulse from atria to the ventricle is not only through the AV node, it is also through that accessory bundle wherein the individual will have a short PR interval, right? So these are all the conditions where you have the presence of loud S1. So you see this question here. A 27-year male patient presented with the cardiac history of atrial septal defect. ECG of the patient is as follows. What will be the abnormality in the first heart sound? Reverse splitting of the first heart sound, pathological splitting of the first heart sound, soft S1, loud S1. So, if you observe the ECG, it is suggestive of right bundle branch block. Right? And how is that you are able to tell it is a right bundle branch block? ECG in detail I have discussed in the section of the ECG, right? So please go through those videos of the ECG, right? They are very, very important. So how is that you are able to tell that it is an ECG of right bundle branch block? You have the presence of M-shaped R wave in V1, right? You can observe that here. It's an M-shaped R wave in V1. And presence of M-shaped R wave in V1 and the S wave, it is wide, right? The S wave in V6, it is wide, or it is like W shaped, but in our ECG it is not exactly W shaped, but it is slightly wide than normal. These 2 points, they favor the right bundle branch block. Now in right bundle branch block, what will happen to the first heart sound? There will be pathological splitting of the first heart sound. Why? Why there will be pathological splitting of the first heart sound? Let me explain you. See, consider this is your right bundle branch and as well as the left bundle branch. Left bundle branch will divide into left anterior division and left posterior division. In a normal individual, what will happen? In a normal individual, both the bundle branches, they receive the impulse from AV node or bundle office simultaneously, and both the ventricles, right, both the ventricles, they contract simultaneously, and thereby you will have M1 followed by the T1. And what will be the duration between these two? That is around 20 to 30 milliseconds. But when there is right bundle branch block, right, but when there is right bundle branch block, what will happen? When there is right bundle branch block, it is the left ventricle which will contract first, then followed by that right ventricular contraction. Right, left ventricle will contract first, then followed by that right ventricular contraction will be there. That is what will happen. And the duration between the M1 and T1, right, the duration between M1 and T1 will be more than 30 milliseconds, right, will be more than 30 milliseconds. So when the duration between M1 and T1 is more than 30 milliseconds, that we call it as the pathological splitting of the first heart sound, right, that we call it as pathological splitting of the first heart sound, where you have M1 after a duration of more than 30 milliseconds, then you have a T1. Why is that? Because the left ventricle is contracting first, followed by that the left ventricular impulse will move to the right ventricle, then there will be right ventricular contraction, and that is the point when there you will have T1, and that will happen in patients with the right bundle branch block. So pathological splitting means the duration is like more than 30 milliseconds between M1 and T1. So you need to know what are the conditions where you have the pathological splitting. Normal splitting means normally you don't have a split. Between M1 and T1 you don't have a split. You will not listen them separately. But in certain clinical scenarios, the distance between M1 and T1 will be more than 30 milliseconds. That is called normal splitting or pathological splitting. and you will come across this in patients with right bundle branch block, and you will come across this in patients with left ventricular pacing. So in left ventricular pacing also the same story. Left ventricle will contract first and followed by that the right ventricle will contract later. Then ectopic beats, right, ectopic beats and idioventricular rhythm originating from left ventricle, right, ectopic beat or idioventricular rhythm originating from the left ventricle. And then Epstein's anomaly. Okay, so these are the conditions where you have the pathological splitting of the first heart sound. Then what about the reverse splitting? Reverse splitting is that you will listen T1 first, then followed by that M1. You will come across this in patients with left bundle branch block, then RV pacing, then ectopic beats, right, ectopic beats originating from the right ventricle. So, and in patients with severe mitral stenosis and myxoma, atrial myxoma, right, severe mitral stenosis and then atrial myxoma. So these are the conditions where you will have reverse splitting of the first heart sound. Now let me explain you the mechanism also, right, but before that let me show you a question. So you see this clinical scenario, a 45-year female presented with syncopal episodes, angina and dyspnea. His ECG is as follows. What is the abnormality in the first heart sound? Reverse splitting of the first heart sound, pathological splitting of the first heart sound, soft S1, absent S1. So first of all you need to diagnose this ECG. This is the ECG suggestive of left bundle branch block, and again I am saying the same. Go back to the sections of the ECG. There I have discussed in detail how to identify RBBB and LBBB and what are their findings. This is the ECG of LBBB. So what will be the findings of LBBB? Number one, they have wide QRS complex, right, where the QRS complex is more than 120 milliseconds. Then you have the presence of deep and wide S wave in lead V1, right, so you can see that here, deep and wide S wave in lead V1, and this S wave, it is of W shaped. Then the other important wave is the R wave, it is of M shape, right, M shaped R wave in V6. So you can observe that here. So in V6 the R wave, it is of M shape, so M shaped R wave in V6. So this will be the findings of the left bundle branch block, and in patients with left bundle branch block there will be reverse splitting of the first heart sound. I will explain you. Now you take this heart where there is a left bundle branch block. So once there is a left bundle branch block, it is the right ventricle which will contract first through right bundle branch, and after the right ventricular contraction you will have the left ventricular contraction later, right, you will have left ventricular contraction later. So you will have T1 then followed by that M1, right, you will have T1 then followed by that M1. So this is your reverse splitting of the first heart sound. Then you see the next question, or right ventricular pacing. So what happens in right ventricular pacing? In these individuals of right ventricular pacing, you can see that here the right ventricle will contract first, thereby you will have a T1, then followed by that left ventricle will contract later, there you have the presence of M1. So you have T1 followed by that M1 in case of the right ventricular pacing, and that will result in reverse splitting of the first heart sound, right? Reverse splitting of the first heart sound. So this is about the story related to first heart sound. So you see a question here. First heart sound is soft in all except short PR interval, ventricular septal defect, mitral regurgitation, the calcified valve. So the answer is the short PR interval. In short PR interval, you have the presence of the loud S1, whereas in VSD, mitral regurgitation and calcified valve, you have the presence of the soft S1. And you see other question. Loud S1, it is caused by calcified mitral valve prolapse, short PR interval, tachycardia, dilatation or widening of the mitral valve after valvotomy. The answer is short PR interval, you will have loud S1, and presence of tachycardia, you have the presence of the loud S1. So this completes the discussion of the first heart sound, right, which occurs during isovolumetric contraction phase. And after the discussion of the first heart sound, let me take up the discussion of the second heart sound. So after having discussed about the first heart sound, now let me take up the discussion of the second heart sound. So the second heart sound, it signals the onset of the ventricular diastole. So when will you listen, or during which phase of the cardiac cycle you will have the second heart sound? You will have the second heart sound during isovolumetric relaxation phase. Right, so during isovolumetric relaxation phase, you will hear the second heart sound, and this second heart sound, it signals the onset of ventricular diastole. It has two components, and these two components include the A2, which is the first component, then the P2, that is the second component, right? A2 first component and then P2 the second component. Now let me explain you the mechanism of the A2 and as well as the P2. So this will be the left atrium, then followed by that left ventricle, which is giving rise to the aorta, and then this will be the aortic valve. So when the ventricle is about to relax, right, when ventricle is about to relax, the pressure within the ventricle reduces. That is, during isovolumetric relaxation phase, the pressure within the ventricle will relax. So the pressure within the ventricle will decrease. Once the pressure within the ventricle decreases, the blood from the aorta will try to regurgitate back, and the regurgitating blood will hit the aortic valve, and thereby the aortic valve, right, thereby the aortic valve, it closes, and this closure will give rise to the A2 on the left side, and similar principle applies on the right side, and that will give rise to the P2. So you have the A2 and then followed by that the P2. This is the mechanism of the second heart sound. Now followed by that, if you take the features of the second heart sound, right, if you see the features of the second heart sound, the frequency, it is a high frequency sound. Right, it is a high frequency sound, and the duration of the second heart sound will be 0.11 second, whereas the duration of the first heart sound, it is 0.14 seconds, whereas the duration of the second heart sound, it will be 0.11 second. And the frequency of the first heart sound, moderate to high frequency, whereas the frequency of the second heart sound, it is a high frequency sound. And the incisura of the aortic pressure, it coincides with A2. Right, incisura of aortic pressure coincides with A2, and incisura of the pulmonary pressure, it coincides with P2. Right, it coincides with P2. And if you take the A2 P2 interval, right, the interval between A2 and P2, During expiration, that will be less than 30 milliseconds. Right, during expiration it is less than 30 milliseconds. And whereas during inspiration, it will be around 40 to 50 milliseconds. Right, during inspiration, it will be around 40 to 50 milliseconds. So, that will be the A2-P2 interval. During expiration, less than 30 milliseconds. During inspiration, 40 to 50 milliseconds. That means during inspiration, you will be able to make out the split, because the duration between the two heart sounds, that is between A2 and P2, is more than 30 milliseconds, wherein you will be able to make out the split. And this particular split, it is a physiological split. Right, this particular split will be the physiological split. And this A2, it is earlier than P2. Right, A2, it is heard earlier than the P2. And A2, it is louder than P2. Right, it is louder than P2 even at the pulmonary area. Right, and this second heart sound, if you see, which particular area it is best heard? Second heart sound, it is best heard in the or at the Erb's point. Right, it is best heard at the Erb's point. So that is about the characteristic features of the second heart sound. And if you see an image based question of the second heart sound, semilunar valve closure is represented by A, B, C, D. So semilunar valve closure, it is represented by, please remember, it is represented by incisura. And which is the incisura? This C point is your incisura. I'll just show you the other image. Yes. So the point C will be your incisura or dicrotic notch. That is the point where the semilunar valve closure is represented. Right? And if you take the other, you take the A. A represent the diastolic pressure and B represent the systolic pressure and the D represent the pulse pressure. That is a difference between systolic and as well as the diastolic pressure. So semilunar valve closure is represented by C, that is your incisura or the dicrotic notch. Now, you should understand the mechanism of the split. See, I said you that the second heart sound, you will be able to make out the physiological split. So now let me discuss the mechanism of the physiological split. And this physiological split, it is heard only during inspiration. And why is that it is heard only during inspiration? Let me discuss. So during inspiration, what happens? The venous return to the right heart increases. Right? Venous return to the right side of the heart, it increases. And as the venous return to the right side of the heart increases, what will happen to the RV volume? The RV volume is also increased. Now, as the RV volume is increased, right ventricle, it takes more time. Okay, right ventricle, it takes more time to empty the blood into pulmonary artery. Right ventricle, it takes more time to empty the blood into pulmonary artery. So, as the right ventricle takes more time to empty the blood into pulmonary artery, accordingly, your P2 is delayed. Right? Accordingly, your P2 is delayed. So, P2 is delayed during inspiration. So, thereby, the distance between A2 and P2 will be more than 30 milliseconds, right? Whereas during expiration, if you take, right, during expiration, so only during inspiration, you will listen that particular split. During expiration, what happens is the LV volume increases. So thereby, left ventricle takes more time to empty the blood into aorta because the LV volume is more. So left ventricle will take more time to empty the blood into aorta. So thereby what will happen to your A2? A2 is delayed. Right? The A2 is delayed. So as the A2 is delayed, A2 it is heard near to P2. So thereby what will happen to the split? The split disappears. Right? The split disappears during expiration. So you don't have the split during expiration. The split is heard only during inspiration. Right? So that is about the mechanism of the split. So if you see this image, right? So during expiration, there is no split. And during this inspiration, a 24-year female pregnant patient presented with sudden onset dyspnea and palpitations. ECG is as follows. What is the abnormality in the second heart sound? Narrow split second heart sound, wide split second heart sound, reversible split second heart sound, absent second heart sound. So, if you see the next important question here, that is 24-year female pregnant presented with sudden onset dyspnea and palpitations, and ECG is as follows. What is the abnormality in the second heart sound? Narrow split second heart sound, wide S2, reverse split second heart sound, absent S2. So first of all, you should be able to diagnose this ECG. So the abnormalities have already been marked here. So now what is this abnormality which is been marked is, so you have the presence of deep S wave in lead 1 and you have the Q wave in lead 3 and the T wave is inverted in lead 3. So this is called as S1 Q3 T3 pattern, right? This is called as the S1 Q3 T3 pattern. So where is that you will have the presence of S1 Q3 T3 pattern? That is present in patients with the pulmonary embolism. And please remember, the most common ECG finding in patients with the pulmonary embolism is the sinus tachycardia. So the sinus tachycardia, this is the most common ECG finding in patients with the pulmonary embolism. Now this S1 Q3 T3 pattern, it is present in almost 7 to 10% of patients. Right, it is present in 7 to 10% of patients. Now in patients with the pulmonary embolism, what will be the abnormality related to the second heart sound? In patients with the pulmonary embolism, let me tell you that there will be increased afterload on the right ventricle. Right, there will be increased afterload on the right ventricle. So because of increased afterload on the right ventricle, what will happen to your P2? The P2 will be delayed. So when the P2 is being delayed, what will happen to your S2? You have a wide split S2. So the answer in this question is wide split S2. Why? Because the ECG, it is suggestive of pulmonary embolism. Now you see the next question. Wide split S2, it occurs in ventricular septal defect, mitral stenosis, atrial septal defect and the coarctation of aorta. So now let me discuss the clinical conditions where you have the presence of wide split S2. There are many clinical conditions where you have the wide split S2. So for wide split S2 to occur, either of these should happen. Either there should be an early A2 or there should be a delayed P2. Then you will have a wide split S2. Now let me discuss the conditions where you have the presence of the early A2. In which scenarios you have the early A2? Early A2 you can have that in mitral regurgitation and as well as in patients with the ventricular septal defect. So in these two clinical scenarios you have the presence of the early A2. So let me just tell you why in case of the mitral regurgitation you have the presence of the early A2. So if you observe in mitral regurgitation, what will happen is the blood from the left ventricle will regurgitate back into the left atrium, right? Some amount of blood will regurgitate back into the left atrium in mitral regurgitation. Thereby what will happen to the amount of blood that has to enter into the aorta? It is reduced. That means compared to normal, the quantity of the blood which enters into the aorta will be less. So compared to normal, when the quantity of the blood which is entering into the aorta is less, so the A2 will be early, right? The A2 will be early because the lesser quantity compared to normal is entering into the aorta. So the aortic valve they closes early, resulting in the early A2. Now another clinical condition where you can have the presence of the early A2 is in patients with the ventricular septal defect. Now what happens in patients with the ventricular septal defect is, for example, you have a defect here in the interventricular septum. So the blood from the left ventricle will enter into the right ventricle. So the quantity of the blood again which is entering into the aorta will be reduced. So in patients with the VSD you have the early A2. Why is that? Because the quantity of the blood which enters from left ventricle into the aorta is less than normal. So thereby what will happen to your A2? The A2 will be early. Right, the A2 will be early. That is what will happen in patients with the ventricular septal defect. So what are the causes for the early A2? Mitral regurgitation and as well as the ventricular septal defect. Now you need to know the conditions where you have the presence of the delayed P2. The delayed P2, first I will tell you the conditions and later I will explain you the mechanism as well. Delayed P2, you will have that in patients with complete right bundle branch block, then in patients with left ventricular premature beat, right, in patients with left ventricular premature beat you have the presence of the delayed P2 and as well as left ventricular ectopic you have the presence of the delayed P2. Now I will tell you the mechanisms also. Now apart from that, what are the other conditions where you have the presence of the delayed P2 is, that is in patients with acute massive pulmonary embolism, right? The other conditions are in conditions like acute massive pulmonary embolism you have the presence of the delayed P2. And another clinical scenario where you will have the presence of delayed P2 is pulmonary hypertension with right heart failure, right? Pulmonary hypertension with right heart failure. And the third scenario where you have the presence of the delayed P2 is in clinical scenarios like pulmonary stenosis with intact interventricular septum. Right, and finally the other condition where you will have is in patients with the ASD, atrial septal defect. So these are all the clinical scenarios where you have the presence of the delayed P2. Now let me explain you the mechanism now. So one important etiology which I have said where there is delayed P2 is in patients with the right bundle branch block. Now why in case of right bundle branch block you will have the delayed P2? So the mechanism is that when the right bundle branch is blocked, both the ventricles they don't contract simultaneously. So the right bundle branch is blocked. When the right bundle branch is blocked, both the ventricles they don't contract simultaneously. In a normal individual, right, in a normal individual, both ventricles they contract simultaneously. Right, they contract simultaneously in a normal individual. But in patients with the right bundle branch block, what happens? Left ventricle will contract first, then followed by that the right ventricle will contract later. Right, followed by that the right ventricle will contract later. So thereby what will happen to your P2? The P2 will be delayed. Right, the P2 will be delayed. That is what will happen in patients with the right bundle branch block. Or you take another scenario. So in a clinical scenario where there is left ventricular premature beat or left ventricular ectopic beat. So right, so there is a left ventricular premature beat, that means there is a left ventricular ectopic, or there is a left ventricular premature beat. In this also it is the same. Left ventricle will contract first, then followed by that right ventricle will contract later in either left ventricular premature beat or left ventricular ectopic beat. Now you take in patients with the pulmonary hypertension, or you take in patients with the pulmonary embolism. So for example, if there is any pulmonary embolism, what will happen to the afterload on the right ventricle? The afterload on right ventricle increases. So when the afterload on the right ventricle increases, what happens? The right ventricle, it takes more time, right? It takes more time to empty the blood. Okay, right ventricle, it takes more time to empty the blood. So whenever there is pulmonary embolism, whenever there is pulmonary hypertension, in both of these, either in pulmonary embolism or in patients with the pulmonary hypertension, the afterload on the right ventricle increases. So when afterload on the right ventricle increases, what happens? It takes more time, that means right ventricle takes more time for the blood to be emptied into the pulmonary artery. So thereby what will happen to your P2? The P2 will be delayed, right? Next, you take in patients with the atrial septal defect. In patients with the atrial septal defect, what happens is, right, let me discuss what happens in atrial septal defect. In atrial septal defect, the blood from the left atrium enters into the right atrium. And right atrium, already it is receiving the blood from inferior vena cava and as well as the superior vena cava. So now the right atrium, in case of atrial septal defect, it has SVC blood, it has IVC blood and as well as the LA blood. Now this large quantity of the blood will enter into the right ventricle. So in patients with the ASD, what will happen to the quantity of the blood in the right ventricle? The quantity of blood in right ventricle increases. Right, the quantity of the blood in the right ventricle increases. So as the quantity of the blood in the right ventricle increases, right ventricle it takes more time to empty the blood into pulmonary artery. Okay, right ventricle, it takes more time to empty the blood into pulmonary artery. So thereby what will happen to your P2? The P2, it will be delayed. Okay, so these are all the conditions where you will have delayed P2. So please remember now, wherever the conditions you have an early A2, like in mitral regurgitation and ventricular septal defect, wherever the condition you have delayed P2, you have the presence of the wide split S2. You have the presence of wide split S2. Okay, next. Now you take the, yes, you see this particular clinical scenario. 54-year male, known case of diabetes mellitus, presented with history of chest pains in 6 hours. On examination, the blood pressure is 134/82 millimeters of mercury. Troponin is positive. The ECG is as follows. What will be the abnormality in the second heart sound of this particular patient? Normal second heart sound, wide split second heart sound, reverse split second heart sound, the absent A2. So first of all, you need to identify the ECG. So once you can identify the ECG, then only you will be able to answer this question here. So you take the ECG, what is that you are observing? First and foremost, there is wide QRS complex. Right, first and foremost, there is wide QRS complex. Then followed by that, if you take the S wave in V1, right? Followed by that, if you take S wave in V1, the S wave in V1, it is wide and deep S wave. Right, it is wide and as well as the deep S wave in V1, and you take the R wave in V6. The R wave in V6, it is broad, right? The R wave in V6, it is broad. Now this particular ECG, it is suggestive of the left bundle branch block. Okay, so in patients with the left bundle branch block, what will happen to the second heart sound? Second heart sound, there will be reverse split second heart sound, right? There will be a reverse split second heart sound. Why there will be a reverse split second heart sound in LBBB? Let me explain you the mechanism. So if you take the scenario of LBBB, left bundle branch is blocked. So when the left bundle branch is blocked, what happens? The which ventricle will contract first? Right ventricle will contract first, and thereby you will have P2. Then later the left ventricle contracts, then you have the presence of A2. So in patients with the LBBB, please remember you have the presence of reverse split of the second heart sound. But there are many conditions where you have the presence of reverse splitting of the second heart sound. So what are the conditions where you have reverse splitting of the second heart sound? Number one, any clinical scenario where there is delayed A2 or any clinical scenario where there is early P2. In this scenario, you have the reverse splitting of the second heart sound. So first, let me tell you the clinical conditions where you have the presence of an early P2. Early P2 will occur in conditions where there is early electrical activation of the right ventricle. So early electrical activation of right ventricle. So wherever there is an early electrical activation of the right ventricle, there will be delayed activation of there will be delayed activation of the left ventricle. There will be delayed activation of the left ventricle. So now you see here, wherever there is delayed electrical activation of the left ventricle or wherever there is early electrical activation of the right ventricle, that is the point when you have the reverse splitting of S2. So reverse splitting of S2 is that where you have the presence of P2 then followed by that A2, right? You have the presence of P2 then followed by that A2. Now where is that you will come across these scenarios? You will come across these scenarios in patients with complete left bundle branch block. Okay, so in patients with complete left bundle branch block, what happens? Again, the concept is simple here. In left bundle branch block, the left ventricle will not contract first, or it will not both the ventricles, they don't contract simultaneously. In left bundle branch block, right ventricle will contract first. Then followed by that, after the right ventricular contraction, it goes to the left ventricle, that will result in left ventricular contraction. So whenever the right ventricle contracts, you will have P2, and whenever the left ventricle contracts, you will have the presence of A2. Okay, next. Now other scenario is right ventricular paced beats and right ventricular ectopic beats. Okay, right ventricular paced beats and right ventricular ectopic beats. See, in case of the right ventricular paced beats and as well as the right ventricular ectopic beats, right ventricle it contracts first, then followed by that the left ventricle will contract later. Next, in clinical scenarios like left ventricular outflow tract obstruction, right, LVOT, left ventricular outflow tract obstruction. So where is that you have the presence of left ventricular outflow tract obstruction where you have reverse splitting of S2, that is in patients with severe aortic stenosis. So in patients with severe aortic stenosis, what happens is the left ventricle, it takes more time to empty the blood into aorta, By the time the right ventricle will contract and it will send the blood into pulmonary artery and the pulmonary valve is closed, and after that the aortic valve will be closed. So please remember, in patients with severe aortic stenosis you will have P2 first and then A2 later, but in case of mild to moderate aortic stenosis you will not have reverse splitting of the S2. Only in case of severe aortic stenosis you will have this scenario. Next, in the patients with hypertensive cardiovascular disease, right, in patients with hypertensive cardiovascular disease, right, in patients with hypertensive, right, in patients with hypertensive cardiovascular disease, whenever there is severe hypertension, that will increase the afterload on the left ventricle, right, that will increase the afterload on the left ventricle. So left ventricle, it will take more time to empty the blood into aorta. So thereby you will have P2 first and then followed by that A2, right, you will have P2 first then followed by that A2. So these are all the conditions where you have the reverse splitting of the second heart sound. So either it is due to early electrical activation of the right ventricle and delayed activation of the left ventricle, right. Now after having discussed about the clinical scenarios where you have the wide splitting and as well as reverse splitting of the second heart sound, you need to know, right. So meanwhile you see this question, wide split second heart sound, it occurs in ventricular septal defect, mitral stenosis, ASD, the coarctation of aorta. So please remember, wide splitting second heart sound, it occurs in VSD and as well as the ASD. In both of these scenarios you have the presence of the wide split S2. The next question is, what are the causes of the fixed split second heart sound? So causes of fixed split S2 are all except atrial septal defect, ventricular septal defect, pulmonary stenosis, acute right heart failure. So the clinical scenario where you have that means the question is what, fixed split S2 all except, that means where is that you have a variable split. You will have a variable split of S2 in the VSD, right. You have a wide split in VSD but it is a variable split. But whereas in ASD, severe pulmonic stenosis and as well as the acute right heart failure. So in these three conditions, that is A, C and as well as D, in these three conditions you have wide fixed split. Right, you have a wide fixed split of the S2, that is in option A, option C and as well as the option D. Right, now let me explain you the mechanism. Let me explain you the mechanism why in case of ASD you have a fixed split. First of all, what do you understand by the word fixed split? Right, first of all, what do you understand by the word fixed split? The word fixed split means the split, it is present both during inspiration, right, both during inspiration and as well as the expiration. Right, the split is present both during inspiration and as well as the expiration. Okay, that is what is the meaning of the word fixed split. In a normal individual, what will happen? Normally, the split, it is present only during inspiration. Right, normally the split is present only during inspiration. The split, it disappears. Right, it disappears during expiration. That is what will happen in a normal individual. But here in case of ASD, you have the split both during inspiration and as well as expiration. And why the split disappears during expiration, the mechanism also I have said you. Okay, now let me tell you what are the reasons, what is a mechanism for a fixed split in the ASD. Let me tell you. So consider this is a 4-chambered heart, mitral valve, then interventricular septum. So during inspiration, right, during inspiration, there is increased quantity of the blood which moves across the right atrium and as well as the right ventricle. So when there is increased quantity of the blood which is passing across your right atrium and right ventricle, so during inspiration what will happen? The P2 will be delayed. Thereby you will have a split, right? I have explained you the same mechanism in the initial part of the S2. And during expiration, what did I tell you? During expiration, right, during expiration there will be increased blood across the, right, there will be increased blood across the left atrium and as well as the left ventricle. There will be increased blood across the left atrium and as well as the left ventricle during the expiration. Alright, now what you have to understand here is, in patients with ASD what will happen? In patients with ASD, you see here, for example, if the individual is expiring, so then what happens? There is increased quantity of the blood which has entered into the left atrium. In ASD, it does not directly enters into the left ventricle. From the left atrium, the blood enters into the right atrium during the expiration process. Right, during the process of expiration, the blood from the left atrium enters into the right atrium during the expiration process, because during expiration large quantity of the blood is through your left side of the heart. That means what? In patients with ASD, even during expiration, there is increased quantity of the blood on the right side of the heart. So thereby what will happen to your P2? The P2 will be delayed, because when the right atrium is receiving the large quantity of the blood during expiration, that large quantity of the blood has to enter into the right ventricle, and from the right ventricle it has to empty into the pulmonary artery. So the P2 it gets delayed because large quantity has to enter into pulmonary artery, and after that the pulmonary valve closes. So the P2 will be delayed. So in patients with ASD, please remember, you have the wide split both during inspiration and as well as expiration, right? Both during inspiration and as well as the expiration. Okay, so that is what is the reason why you have a fixed wide split in patients with the ASD. Now you need to know, right, so to summarize, what are the causes for wide fixed split? ASD, severe pulmonary stenosis, then in patients with acute right heart failure. Right, acute right heart failure. Okay, next, then you need to know what are the causes of the single S2. See, the causes of the single S2, see, why there should be a single S2? Either there should be a delayed A2, right? Either there should be a delayed A2 that will merge with the P2. Either there should be a delayed A2 that will merge with the P2, or there should be, right, or there should be an early P2 which will merge with the A2, right, or there should be an early P2 which will merge with the A2. In both of these scenarios, you will have the presence of the single S2. Now, where do you come across this scenario? That is in patients with the aortic stenosis. Right, that is in patients with the aortic stenosis. So in patients with severe aortic stenosis, what will happen? The A2 will be delayed. The A2 will be delayed to such an extent, it may merge with the P2. Then you will listen a single S2. Right, then you will listen a single S2. Then the conditions like emphysema, conditions like obesity, right, and conditions like, so in emphysema and as well as obesity, the breath sounds, they are not transmitted onto the surface of the chest, right? Breath sounds, they are not transmitted adequately onto the surface of the chest. Thereby what will happen to your S2? The S2, it will be single. So emphysema and as well as obesity, the intensity of the sounds are not adequately transmitted onto the surface of the chest, and thereby you will have the presence of a single S2. Okay, so these are the conditions where you will have single S2, in the sense you don't have A2 and P2 being differentiated. The next important question is S2 is best appreciated in third left heart sound, second right intercostal space, fourth left intercostal space, fifth left intercostal space. So please remember S2 it is best appreciated in the Erb's point, which is nothing but the third left intercostal space. But if individually the question is asked, where will you appreciate A2 better? A2 better it is appreciated in the second right intercostal space. And where will you appreciate the P2 better? P2 it is better appreciated in the second left intercostal space. Right? Both A2 and P2, both of them together, where will you appreciate that better? That is in the third left intercostal space. Right? So S2 it is best appreciated in the third left intercostal space. Okay. Next. Now, Erb's point in cardiology refers to right second intercostal space, left second intercostal space, right third intercostal space, left third intercostal space. So Erb's point in cardiology, please remember it refers to left third intercostal space. So that is about the second heart sound. Now see, one point you have to remember here is that in patients with the aortic stenosis, depending upon the severity, either you can listen it as a single S2 or you can listen it as a reverse S2. In case just now in patients with severe AS, what is that I have discussed? There can be a reverse S2 also. Reverse S2 means what? Where you have a P2 first and then A2. So depending upon the severity, like for example in moderate AS there can be a single S2, and in severe AS or in very severe AS, right, in very severe AS you will have the reverse split S2 where you will have P2 first and then followed by that the A2, right. So that is about the second heart sound. Now after having discussed about the second heart sound, now let me tell you about the third heart sound. So in second heart sound, what are all the nutshell points? The nutshell points are that second heart sound, it is a high pitched sound and it is heard with the diaphragm of the stethoscope, and the duration of the sound is 0.11 second. Right, and your A2 and P2 are the two components of the second heart sound. A2, P2, you have a physiological split during inspiration, but the split will disappear during expiration. Right, the split will disappear during expiration. Okay, that is one thing. And then followed by that, the points is mainly about the split. Where do you have a wide split? Wide split will be there due to an early A2 and delayed P2. Where do you have a reverse split? Reverse split will be there, that is due to delayed A2 and early P2. That will cause the reverse split. And what are the causes of wide fixed split? That is in ASD, severe pulmonary stenosis and acute right heart failure. And what is the mechanism? I have already discussed that. Okay, right. Now after having discussed about the second heart sound, now let me tell you about the third heart sound. Third heart sound is best, right, it is best heard with options A, that is bell, option B, that is head, option C, that is diaphragm, option D, that is tubing. So third heart sound, please remember it is a low pitched sound. Right, it is heard, it is a low pitched sound. So low pitched sounds, they are heard better with the bell of the stethoscope. High pitched sounds, they are heard better with the diaphragm of the stethoscope. Okay, so the answer is A, that is bell. Then third heart sound is best heard at and question is at aortic area, pulmonary area, Erb's point, tricuspid area, the mitral area. So let me tell you, third heart sound is best heard at the mitral area. So which is nothing but the apex of the heart. Right, which is nothing but the apex of the heart. Okay, next, then followed by that, let me tell you that third heart sound normally it is not heard, but there are certain conditions where you have physiological S3 and there are certain conditions where you have a pathological S3. Both of that let me discuss. So the question is, physiological S3 is heard in all except age up to 40 years, children, pregnancy, and then the sumo fighters. Now, let me discuss about the third heart sound and then come back to this question. Third heart sound, it is also called ventricular diastolic gallop, or it is also called a protodiastolic gallop. So, why does this third heart sound occur, and during which phase of the cardiac cycle you have this third heart sound? Third heart sound, it is heard in first rapid filling phase of the ventricle. Okay, so it is heard during first rapid filling. Right, it is heard during the first rapid filling of the ventricle. And please remember, third heart sound has its origin within the right ventricle or left ventricle or both. So, the origin is in the right ventricle or in the left ventricle. Right, the origin is either in the right ventricle or within the left ventricle. And because the origin is in the ventricle, we call this as ventricular diastolic gallop. We call this as ventricular diastolic gallop. And why is it called diastolic gallop? Because your third heart sound, it is a diastolic sound. Okay, and that too, which phase of the cardiac cycle you listen that? In the first rapid filling. And the first rapid filling, it is an early diastolic sound. Right, first rapid filling is nothing but your early diastole. Right, it occurs during early diastole. So, it is an early diastolic sound. And I have said you that it is a low pitched sound. Right, it is a low pitched sound. Okay, and if you listen in S3, right, if you listen in S3, it will be always an exaggeration of the physiological S3. So, what is pathological S3? Pathological S3 is exaggeration of exaggeration of the physiological S3 with the same mechanism. And this third heart sound, it is best heard at the apex of the heart. Right, it is best heard at the apex of the heart. And in which position? In the left lateral position. Right, it is best heard at the apex of the heart in left lateral position. And how do you hear that? You will hear that with the bell of the stethoscope. So, that is about the basic introduction of the third heart sound. Then, what are the conditions where you have the presence of the physiological S3? Physiological S3, it is heard in children and young adults. Right, children and young adults, you have this physiological S3. And the physiological S3 is also heard in the athletics. And physiological S3 is also heard in the pregnancy. So, these are all the scenarios where you will have the physiological S3. But what are the conditions where you have the pathological S3? So, pathological S3 is heard in scenarios where there is ventricular dysfunction. Right, where there is ventricular dysfunction. So, when there is ventricular dysfunction, what will happen to the systolic function? There will be a poor systolic function. So, when there is a poor systolic function, right, when there is a poor systolic function, what will happen to the LV in systolic volume? It increases, because when there is a poor systolic function, the ventricle is unable to empty the blood into the aorta. So, LV end systolic volume increases. When LV end systolic volume increases, to this left ventricle at the end of the systole, large quantity of the blood is remaining compared to normal. To this ventricle where there is a blood remaining at the end of the systole, now it will receive the blood from the atria. So thereby what will happen to LV end diastolic volume? Increases. Why? Because in this left ventricle now you have a systolic volume, that is increased end systolic volume. To this blood, LA blood, to this LA blood is added. So by the end of the diastole there is increased LV end diastolic volume. So now in these patients with the ventricular dysfunction, the left atria or the right atria are sending the blood into the ventricle which is already containing the blood. Why? Because of the systolic dysfunction, the entire blood was unable to get emptied. So your atria is sending the blood into the ventricle which is already containing the blood. So thereby what will happen to the S3? S3, it gets exaggerated. S3 is due to first rapid filling, and here to this first rapid filling already there is blood within the ventricle. So thereby what will happen to your S3? There will be a pathological S3, right? There will be a pathological S3. So now what are the conditions where you have the ventricular dysfunction? You will have that in patients with the dilated cardiomyopathy. You will have that in patients with the ischemic heart diseases. You will have that in patients with valvular heart diseases. So which particular valvular heart diseases will cause the ventricular dysfunction? That is in patients with MR, that is in patients with AR, that is in patients with the AS, aortic stenosis, right? Next, in patients with systemic, right, that is in patients with systemic and pulmonary hypertension, right, that is in patients with systemic and as well as pulmonary hypertension, you have the presence of the pathological S3, right. So pathological S3 is present in clinical conditions where there is ventricular dysfunction, and these are all the conditions where there will be ventricular dysfunction, right. Next, now having said this, you see this question. A patient is admitted with pneumonia. A murmur is heard on examination. What finding points to chronic severe mitral regurgitation? That means what are the points in favor of the chronic severe mitral regurgitation? Murmur louder on inspiration, presence of S3, murmur louder over the right second intercostal space midclavicular line, Corrigan sign, the narrow pulse pressure. So in severe mitral regurgitation, you have the presence of the pansystolic murmur, and all your left sided murmurs, let me tell you, they increase on expiration, right. All the left sided murmurs, they increase on expiration. So murmur louder on inspiration is a wrong statement. Next, narrow pulse pressure. Narrow pulse pressure, it is a feature of the aortic stenosis, not the feature of mitral regurgitation. In patients with mitral regurgitation, let me tell you, they have wide pulse pressure, right, they have wide pulse pressure. Corrigan sign, right, which is nothing but the dancing carotid, that is a feature of the aortic regurgitation. So Corrigan sign is a wrong statement. Murmur louder over the right second intercostal space midclavicular line, that is a wrong statement, because in patients with the severe mitral regurgitation, you will have the pansystolic murmur at the apex of the heart, and that murmur from the apex, it will radiate to the axilla, and from the axilla it will radiate to the angle of the scapula, right, it will radiate to the angle of the scapula. And in patients with the severe mitral regurgitation, let me tell you, they land up in the heart failure, right, they land up in the heart failure. So once they land up in heart failure, there is development of ventricular dysfunction. So once there is development of ventricular dysfunction, there you have the presence of the third heart sound. There you have the presence of third heart sound. So presence of S3 is due to the development of ventricular dysfunction secondary to the heart failure, and that heart failure is due to chronic severe MR. So that is about the clinical question related to your the S3. Now, then let me tell you, this S3, it is not just present only in clinical scenarios of ventricular dysfunction. It is also present in clinical conditions of the hyperkinetic states. Right, hyperkinetic states. So what are the hyperkinetic states? The hyperkinetic states include anemia, thyrotoxicosis, beriberi, AV fistula, pregnancy, fever. All these are hyperkinetic states. So in all the hyperkinetic states, you have the presence of the pathological S3. Then in patients with the cardiomyopathies, right? So what are those cardiomyopathies where you have the presence of the pathological S3? That is in patients with the restrictive cardiomyopathy, and as well as in patients with the hypertrophic cardiomyopathy, and as well as in patients with the dilated cardiomyopathy, you have the presence of the pathological S3, right? So after having discussed about the S3, now let me just show you the questions which I have discussed. So yes, physiological S3 is heard in all except age up to 40 years, children, pregnancy, sumo fighters. So what did I tell you? S3 is heard in young adults. Physiological S3 is heard in young adults. And what is the definition of a young adult? Definition of a young adult is age up to 40 years is a young adult. And children, physiological S3 is heard. Pregnancy, physiological S3 is heard. But let me tell you, in sumo fighters, you don't listen the S3 because sumo fighters, they are extremely obese individuals. So when you are auscultating an obese individual, the heart sounds will be muffled. The heart sounds will be muffled. Okay. So that is about the physiological S3. Then third heart sound, it is seen in all except athletes, mitral stenosis, constrictive pericarditis, left ventricular failure. In athletes, you will have third heart sound. In constrictive pericarditis, let me tell you, even in patients with the constrictive pericarditis, there is increase in the atrial pressure. Right, there is increase in the atrial pressure. So when the mitral valve or tricuspid valve opens, the blood from the atria enters into the ventricle. Right, the blood from atria enters into the ventricle with high pressure. Right, the blood from the atria enters into the ventricle at a very high pressure, and thereby you will have the presence of pathological S3. Pathological S3 is heard in the constrictive pericarditis, and pathological S3 is also heard in left ventricular failure. So where is that you will not have S3 is in mitral stenosis, because in mitral stenosis the valve is stenosed. Right, the valve is stenosed. So when the valve is stenosed, your first rapid filling does not take place because the valve is not opening properly. You will have third heart sound only during first rapid filling phase. But when the valve is not able to open properly, where is the question of the rapid filling of the ventricle does not occur. Thereby, you don't have the third heart sound in patients with the mitral stenosis. Right? Next, then followed by that, yes, you see this question. A 78-year-old woman is admitted with heart failure. Right, admitted with heart failure. The underlying cause is determined to be the aortic stenosis. Which sign is most likely to be present? Pleural effusion on the chest X-ray, raised jugular venous pressure, bilateral pedal edema, prominent S4, atrial fibrillation. So, in patients with aortic stenosis, what will be the characteristic heart sound or an additional heart sound which is heard is the prominent S4. Now let me discuss about the S4 and then again let me come back to this particular question. So if you take the fourth heart sound, this is also a low pitched sound. Right, this is also a low pitched sound, and this fourth heart sound is heard just before the systole, that is in the later part of the diastole. So it is a late diastolic sound, or we call this as a pre-systolic sound. right, or we call this as a pre-systolic sound. And this fourth heart sound, it is produced in ventricle during second rapid filling. So during which phase of the cardiac cycle? That is during second rapid filling phase, you will hear the fourth heart sound. But let me tell you, the third heart sound and fourth heart sound, normally it is not heard with the stethoscope. So for listening the third and as well as fourth heart sound, normal third and normal fourth, if you want to listen, you require the phonocardiograph. Right, you require a phonocardiograph to listen the third and as well as fourth heart sound normally. But pathological S3, pathological S4, you can listen that with the stethoscope as well. And what is the event? What is the event which is happening within the atria during second rapid filling? Second rapid filling, it is caused due to atrial contraction. Right, it is caused due to atrial contraction. And the other point is S4, it is never present in normal individual. Right, it is never present in normal individual. Presence of S4, it is always pathological. Right, the presence of S4, it is always pathological. And this S4, where do you listen that? In which area of auscultation you will listen this? You will listen that at the apex of the heart. Right, it is best heard at the left ventricular apex when the patient is placed in the left lateral position. Right, when the patient is placed in the left lateral position, there you will listen the fourth heart sound. Now let me tell you the conditions where you will have the fourth heart sound. See, for you to listen the fourth heart sound, what would be the prerequisite? So you see here, this is your left atrium and this is the left ventricle giving rise to aorta, and this is your aortic valve. Right, so this is left atrium and then left ventricle. Now when left atrium contracts, left ventricle should be in a position to receive the blood, and because of left atrial contraction you will get the fourth heart sound. For suppose if there is left ventricular hypertrophy, right, if there is left ventricular hypertrophy, so when there is left ventricular hypertrophy, right, when there is left ventricular hypertrophy, what will happen to the pressure in the left ventricle? Pressure in the left ventricle grossly increases. So when the pressure in the left ventricle grossly increases, left atria, it has to contract very strongly. Right, left atria, it has to contract very strongly. Understood? So when left atria contracts strongly, that is the point when you will hear the fourth heart sound. Okay, so wherever the condition there is development of left ventricular hypertrophy, like you take in left ventricular outflow tract obstruction or right ventricular outflow tract obstruction, right, you take in either LVOT or RVOT, that means either in patients with aortic stenosis or in patients with the pulmonary stenosis, there is development of left ventricular hypertrophy or right ventricular hypertrophy, the pressures within the ventricle is high. When the pressures within the ventricle is high, atria, they have to contract very strongly to push the blood into the ventricle, and thereby you will have the fourth heart sound. Next, you take in patients with systemic hypertension or pulmonary hypertension. So in systemic hypertension or pulmonary hypertension, same, there will be increased afterload on the ventricles, Once there is increased afterload on the ventricles, there will be ventricular hypertrophy. Once there is ventricular hypertrophy, the pressures within the ventricle increases and atria, they have to contract very strongly to push the blood into the ventricle, and thereby you will have the fourth heart sound. And then in patients with the HOCM, hypertrophic obstructive cardiomyopathy, there also the ventricular pressure increases. Right? Next, in patients with ischemic heart diseases like acute myocardial infarction. In acute myocardial infarction, what will happen? There will be a systolic dysfunction. So once there is a systolic dysfunction, the LV end systolic volume increases. So the quantity of the blood in the ventricle increases at the end of the systole. Now after the systole, the ventricle has to receive the blood from atria. So atria has to send the blood into the ventricle, which is already having the blood. So in such case, the atria has to contract very strongly to push the blood into the ventricle. So once there is a stronger atrial contraction, you have the presence of the S4. Next, you have the presence of S4 in all the hyperkinetic states, that is in patients with anemia, thyrotoxicosis, AV fistula, beriberi, and pregnancy. So these are all the hyperkinetic states where you have the presence of the fourth heart sound. Then in patients with the heart block, right? Then in patients with the heart block, there also you will have a stronger atrial contraction to push the blood into the ventricle. So there you will have again the fourth heart sound. So these are all the conditions where you have the presence of fourth heart sound. Now let me just give you a mnemonic, right? The mnemonic is HOCM. The word H stands for hypertrophic obstructive cardiomyopathy. The word O of HOCM, obstructive, right? Obstruction or obstructive valvular diseases. What are those obstructive valvular diseases? That includes aortic stenosis, then the pulmonary stenosis. Then C stands for cardiac tamponade. Cardiac tamponade also, ventricular pressures are very high, right? And atria has to contract very strongly to push the blood into the ventricle. So you will have an S4. Then M stands for myocardial infarction. So in nutshell, these are the causes for the fourth heart sound. Now I'll just show you a question. A 79-year-old woman is admitted to the coronary care unit with unstable angina. She is started on appropriate medication to reduce her cardiac risk. She is hypertensive, fasting glucose levels are normal, cholesterol is 5.2. She is found to be in atrial fibrillation. What is the most appropriate sign? Loud S1, wide split S2, absent S4, pathological S3, mid-systolic click. So, in patients with the atrial fibrillation, there will be a very feeble atrial contraction. So, when there is a feeble atrial contraction, you will not have S4 at all. There will be absent S4. Why? Because the individual is in a state of the atrial contraction. The individual is in a state of atrial fibrillation, where you have the feeble contraction of the atria. So thereby there is absent S4. So after having discussed about the various heart sounds, that is S1, S2, S3, S4, now let me just give you the comparison of all the four heart sounds. So if you take the first heart sound and as well as the second heart sound, both of them, they are the high pitched sounds. Right, both of them, they are the high pitched sounds. Whereas the third and as well as the fourth heart sound, they are low pitched sounds. Right, the third and as well as fourth heart sounds, they are the low pitched sounds. Okay. Now, the first heart sound, it is slightly prolonged, whereas the second heart sound, it is shorter. So the first heart sound, like we consider it as lub, which is slightly prolonged, and the second heart sound, it is the dub, right? It is shorter. Now if you take the duration of these sounds, first heart sound duration is 0.14 second, second heart sound duration is 0.11 second, and third heart sound duration is 0.1 second, and fourth heart sound, it is also around 0.1 second. So that will be about your fourth heart sound. And if you take the frequency of these particular heart sounds, the first heart sound, the frequency is 25 to 45 hertz. Right, 25 to 45 hertz is the first heart sound. And second heart sound, the frequency is around 50 hertz. And the third heart sound and as well as the fourth heart sound, the frequency is less than 20 hertz. Right, less than 20 hertz. Okay. Now, what exactly is the cause of these particular heart sounds? So, if you take the first heart sound, it is due to the closure or due to vibration which is generated within the mitral and tricuspid valve. So, it is the vibration which is generated in the mitral valve and as well as the tricuspid valve. And if you take the second heart sound, it is due to closure of the aortic and pulmonary valve. Right, it is due to closure of aortic and as well as the pulmonary valve. That will be the second heart sound. And if you take the third heart sound, it is due to rapid ventricular filling in the first phase of diastole or in the early phase of diastole. So it is due to first rapid filling. Right, it is due to first rapid filling. And if you take the fourth heart sound, it occurs during second rapid filling. Right, it occurs during the second rapid filling. Okay. Then coming to the timing of the sound. So that means during which phase of the cardiac cycle does this occur? So the first heart sound, it starts with the onset of ventricular systole, that is during isovolumetric contraction phase. And if you take the second heart sound just after the end of ventricular systole, that is during isovolumetric relaxation phase, you have the presence of the second heart sound. And the third heart sound, the beginning of middle third of the diastole, that is during which phase of the cardiac cycle you will have this? That is in the first rapid filling. Actually, the cause is also the same. It is because once the atria, that is when the mitral valve and tricuspid valve open, the blood from the atria will gush into the ventricle and it will hit the ventricle, and thereby you will have you will listen a sound that is called the S3. So it is during the first rapid filling, the same. Whereas if you take the second heart sound, right, if you see the second heart sound, which is due to second rapid filling, so that is due to atrial contraction. Right, that is during atrial contraction. That is the point when you will listen the fourth heart sound. And when is this being heard? The first heart sound, or what it is being heard better with? The first heart sound, it is better heard with diaphragm. Right, it is better heard with diaphragm. And second heart sound, this is also better heard with diaphragm. Right, and whereas the third heart sound, it is better heard with the bell of the stethoscope. And fourth heart sound, this is also better heard with the bell of the stethoscope. Okay, so third and fourth heart sound, they are better heard with the bell of the stethoscope. So this is about the heart sounds, first, second, third, and as well as the fourth heart sound. Now, after having discussed about the heart sounds, let me take up the discussion of the additional sounds that you will listen in the cardiology. So the question is, a 45-year-old woman complains of increasing shortness of breath on exertion as well as the orthopnea for the previous 3 to 4 months. She had previously recovered from pericarditis about a year earlier. On ECG, there is low voltage complexes, especially in the limb leads, and the chest X-ray shows the pericardial calcification. The presumptive diagnosis is the constrictive pericarditis. Which of the following physical signs would be consistent with this? The pericardial knock, third heart sound, fourth heart sound, rolls at the base of both the lungs, loud first and second heart sound. Okay, so you need to know the diagnosis which is already given, which is the constrictive pericarditis. Now, let me tell you what are all these additional sounds. In constrictive pericarditis, you will listen at an additional sound that is called pericardial knock. Right? Let me discuss about this particular pericardial knock and all other additional sounds. So, one of the very important additional sound that you need to know is about the ejection click. So, ejection click, let me tell you, it is a systolic sound. And in which scenarios you will listen this particular ejection click? Ejection click, it is a sharp, high-pitched sound heard in aortic stenosis and pulmonary stenosis. Right? So, it is a sharp, high-pitched sound. Right? It is a sharp, high-pitched sound. And where is it heard? It is heard in patients with the aortic stenosis and pulmonary stenosis. And why does it occur? It occurs due to opening of it occurs due to opening of stenosed aortic and pulmonary valve. Right, it occurs due to opening of stenosed aortic and pulmonary valve. And let me tell you, normal opening of the valve, if the aortic valve and pulmonary valve, if it opens, it does not produce any sound. But if it is like stenosed aortic valve, stenosed pulmonary valve, if it opens, this will produce a sound. And that is what is nothing but your ejection click. And let me tell you, it is a systolic sound. Now, why is that we need to consider it is a systolic sound? Right? Why is that we need to consider it to be a systolic sound? Why? Because the aortic valve, that is stenosed aortic valve, will open during the systole for the ejection of the blood from the ventricle into the aorta. Now, because the stenosed aortic valve is opening during the systole, that is the reason why it is considered to be a systolic sound, which is a sharp, high-pitched sound. Right? So, and which phase of the systole? It is heard in the early systole. Right, it is heard in the early systole. Okay, right. So that is about the ejection click. Now, after having discussed about the ejection click, let me discuss about the another important additional sound, that is the opening snap. So opening snap, it is a brief, high-pitched sound. Right. So opening snap, it is a brief, right, it is a brief, high-pitched sound, and it is heard in clinical scenarios like mitral stenosis and tricuspid stenosis. And why does this occur? It occurs due to opening of stenosed mitral and right, it occurs due to opening of stenosed mitral and the tricuspid valve. Normally, opening of your mitral valve and opening of the tricuspid valve does not produce any sound. But if it is a stenosed valve, when it opens, it will produce a sound, and that is what is called as the opening snap. And when will this your mitral valve and tricuspid valve open? The mitral valve and tricuspid valve will open during the diastole of the ventricle. And that is the reason why this opening snap, it is considered to be a diastolic sound. Right, it is considered to be a diastolic sound. And this opening snap, it is heard after the second heart sound. right? It is heard after S2, right? And after how much time of your S2 you will listen this opening snap is after A2, right? After A2 it is heard between, right? It is heard between 0.04 to 0.12 seconds, right? It is heard after A2, that is between 0.04 to 0.012 seconds after A2 you will listen this particular opening snap, okay? And it is heard in these two scenarios, that is mitral stenosis and as well as the tricuspid stenosis. Now after having discussed about the opening snap, the next important additional sound is the pericardial knock. So where will you listen this pericardial knock? You will listen this pericardial knock in patients with the constrictive pericarditis. Now in patients with the constrictive pericarditis, what will happen is the pericardium, it becomes thick and calcified, right? The pericardium, it becomes thick and calcified. So when the pericardium is thick and calcified, the ventricles, they cannot have a complete relaxation. Ventricles, they will relax and suddenly stops, because this thickened pericardium will not allow the ventricle to relax. So when the ventricular relaxation is suddenly stopped because of the thickened pericardium, that will produce a sound, and that is called pericardial knock. So pericardial knock, let me tell you, which is heard in constrictive pericarditis, it is heard during diastole. So that is the reason why this is considered to be a diastolic sound, right? That is the reason why it is considered to be a diastolic sound. And let me tell you, even your pericardial knock, it is a high pitched sound, right? Even your pericardial knock, it is a high pitched sound, okay? And this pericardial knock, it is audible during early phase of diastole, right? It is audible during early phase of the diastole. And where is it heard? It is seen in patients with a constrictive pericarditis, and it is produced due to sudden deceleration of the ventricular filling, right? So it is produced due to it is produced due to sudden deceleration of it is produced due to sudden deceleration of the ventricular filling. That is what is the mechanism for the pericardial knock, which is a high pitched sound. So all these are your high pitched sounds now. Your ejection click is a high pitched sound, opening snap is a high pitched sound, and even your pericardial knock is also a high pitched sound. Then coming to the tumor plop. See, tumor plop is a characteristic low pitched sound. Right, it is a low pitched sound. And where is that you will listen this tumor plop? You will hear that in the atrial myxoma. Now let me explain you the mechanism of the tumor plop. Right, let me explain you the mechanism of the tumor plop. So tumor plop is what? Tumor plop, it is a low pitched sound. Okay, now you see here, consider 4-chambered heart. This is your mitral valve, and this is the tricuspid valve, and this is the atrial myxoma. So when the atria contracts, right, when the atria contracts, the myxoma, it comes and touches the mitral valve annulus. When the myxoma comes in contact with the mitral valve annulus, that is the point when you will listen a sound, right? That is the point when you will listen a sound, and that is called the tumor plop. So when atria is contracting, ventricle will be in a state of diastole. and that is the reason why your that is the reason why your tumor plop is considered to be a diastolic sound. That is the reason why it is considered to be a diastolic sound. So please remember, tumor plop which is heard in a atrial myxoma, it is a diastolic sound and it is a low pitched sound. You take all the first three, so among these all added sounds, the ejection click, opening snap and pericardial knock, all these are the high pitched sounds, right? All these are the high pitched sounds, whereas the tumor plop, it is a low pitched sound, right? Whereas the tumor plop, it is a low pitched sound. Okay, next. So if you see a question here, all of the following heart sounds occur shortly after S2 except opening snap, pericardial knock, ejection click, the tumor plop. The answer is the ejection click. Ejection click, it is a systolic sound, whereas if you take the other added sounds, they are the diastolic sounds, right? They are the diastolic sounds. So this is the first heart sound, then we have second heart sound, then first heart sound. Okay, so exactly in the early part of the systole, you have the ejection click, and this ejection click, it is heard before S2, whereas all other sounds like opening snap, then the tumor plop or the pericardial knock, all these are heard after S2, right? All these are heard after S2. So these are all the diastolic sounds, and ejection click, it is a systolic sound. So all of the following heart sounds occur shortly after S2 except, so what is the answer here? Ejection click. Ejection click is the one which will occur after S1 or before S2. Okay, right. Now after having discussed about these sounds, let me just summarize what are all the diastolic sounds and what are all the systolic sounds. So late diastolic sounds will be S3 and as well as S4, and even you take S3, it will be in between your opening snap. Opening snap is an early diastolic sound, then S3 will be somewhere in the middle of the diastole, and S4 will be completely a late diastolic sound. So S3, it will be in between, it can be considered as a mid diastolic sound, and ejection click and as well as mid systolic click will be the systolic sounds. And where will you have this mid systolic click? You will have that in patients with the mitral valve prolapse syndrome. Then early diastolic sounds are pericardial knock, opening snap, tumor plop, and then the quadruple rhythm. These are all the early diastolic sounds. So this is about the heart sounds. Now you just see one more question. Yes, a 59-year-old man presents for a well-person check. A cardiovascular, respiratory, gastrointestinal, neurological examination is performed. No significant findings are found except during auscultation, a mid-systolic click followed by a late systolic murmur is heard at the apex. The patient denies any symptom. The most likely diagnosis is. So what is the sound here? Added sound. You have a mid-systolic click, then followed by that a late systolic murmur, right? Followed by that a late systolic murmur. So these added sounds, you will have that in patients with the mitral valve prolapse syndrome, MVPS. So, and what is another name of mitral valve prolapse syndrome? This is called as the Barlow syndrome, right? This is called as the Barlow syndrome, and this particular table will show you the summary of all the added sounds whatever I have just discussed now. Okay, next you see another question. You have seen a 57-year-old woman who presents with worsening shortness of breath coupled with exercise intolerance. She had rheumatic fever in her adolescence and suffered from essential hypertension. On examination, she has signs which point to a diagnosis of mitral stenosis. Which of the point is not clinical sign associated with mitral stenosis? Opening snap, atrial fibrillation, pansystolic murmur which radiates to axilla, tapping undisplaced apex beat, right ventricular heave. So What is the answer in this? It is the pansystolic murmur which radiates to axilla. So pansystolic murmur which radiates to axilla, it is heard in mitral regurgitation, whereas opening snap, it is an added sound. Right, opening snap, it is an added sound which is heard in the mitral stenosis. And atrial fibrillation, it is the complication of mitral stenosis that is due to enlarged left atrium. Okay, and tapping undisplaced apex beat, it is a characteristic apex beat in patients with mitral stenosis. And in patients with mitral stenosis, there will be development of right ventricular heave, and that is due to pulmonary hypertension. So in mitral stenosis, when they develop pulmonary hypertension, there will be increased afterload on the right ventricle, and because of this increased afterload on the right ventricle, there will be development of right ventricular hypertrophy, and thereby the individual will have the right ventricular heave on palpation. Next, the next question is, mid-systolic click is classically heard in mitral valve prolapse, the Hamann-Ridge syndrome, rheumatic aortic regurgitation, congenital mitral stenosis. So mid-systolic click, it is classically heard in patients with the mitral valve prolapse, right? It is classically heard in patients with the mitral valve prolapse. So to summarize, S1 and S2, S1 during isovolumetric contraction phase, S2 during isovolumetric relaxation phase, pericardial knock, a diastolic sound. Tumor plop, it is also a diastolic sound which is a low pitched sound which is heard in atrial myxoma. Then opening snap, this is also a diastolic sound which is heard in patients with the mitral stenosis. Quadruple rhythm, it is seen in patients with the left ventricular failure. Quadruple rhythm means what? Along with S1 and S2, you will also listen S3 and as well as S4. And what do you mean by the word incomplete summation gallop? When S4 and S3 occurs together at a faster heart rate, then we call it as an incomplete summation gallop. So this is about the discussion of the heart sounds and as well as the added sounds. Thank you very much.